Proper visible, doctor?
No, this is the starting part for me, right?
Yes, yes, doctor.
What is your doubt?
No, it's visible, no? Proper,
Yeah,
doctor.
yeah, yeah. It is visible.
Okay.
Sure. Today it also happens to be the I think the Young Ophthalmologists Association is having their first physical uh, I think annual meet.
Annual conference, doctor.
Yeah. So a lot of some similar events are happening today.
Okay.
I had realized, Dr. Roshmi, that I have done everything to put myself in a D&D mode, but my cat is in the room. I, I will send him out. No, it's okay. Go. Go.
Shall we start, doctor?
Sure, let's do that. Hello, everyone. Welcome to this session we are having today virtually for all of you from GHA. This session is something that we've been really looking forward from a very long time, and I'm so happy that it is materializing today. A few words about GHA. We are India's leading med education company. At GHA, our mission is to nurture pool of competent and passionate human resources, catering to ever-evolving needs of the healthcare sector. And we believe in mixing technology with tradition to unlock the potential of learning, as it plays a major role in each step of our educational journey. And our core purpose lies in bridging the crucial skill and knowledge gap that often exists between traditional education and dynamic requirements of the healthcare industry. So to offer this, we are offering a diverse array of different academic verticals. One of them is the CME vertical. And today I'm glad that, in the CME vertical, we are launching the first ophthalmology related education event, which is going to be an offline event in Bangalore. But as a precursor to that, I am so glad to invite our today's speaker and also the course director, Dr. Roshmi Gupta. So Dr. Roshmi, welcome to the session. So glad to have you here. Dr. Roshmi is our course director for the upcoming workshop, and she's a leading oculoplasty surgeon and orbit specialist, as you all know. Dr. Roshmi has over 2 decades of experience as an oculoplasty surgeon and ocular oncologist, and she's been instrumental in setting up departments of ocular oncology and plasty in Naran Netralaya, Bangalore. She's had her training from prestigious institutes like the L.V. Prasad Institute and the Moorfields Hospital in London in various areas of oculoplasty and ocular oncology, and also has numerous national and international papers to her credit. This much of time is not really enough to cover completely her introduction. Dr. Roshmi now is practicing in Bangalore, and she, being a keen academician, has consented to be part of the GHA initiative, and so glad to have her here as a speaker for a little bit of an understanding of the surgical anatomy of the orbit before we go into the main workshop. I welcome you all once again here. Please do enjoy the session from Dr. Roshmi, and I hand it over to Dr. Roshmi.
Thank you, Dr. Jayashree, for that very kind introduction. And it's a privilege to be here with all of you today. I'm going to start sharing my screen. Okay, is the screen visible?
Yes, doctor.
Okay, so welcome to this webinar on the surgical anatomy of the orbit. I hope all of you are staying well in this awful weather. I am Dr. Roshmi Gupta, and I practice orbit, oculoplasty, and ocular oncology in Bangalore. Today, the topic is surgical anatomy of the orbit. All of you are already ophthalmologists. You don't need to be taught first-year anatomy. However, what we are looking at is how exactly the anatomy of the orbit influences our decision and the steps we take during surgery of the orbit. So overall, we are going to be covering an overview and dimensions of the orbit, the walls of the orbit, the bones, the relations of each wall, landmarks, and relevance of the landmarks, relationship of muscles, nerves, and blood vessels, and the approaches to the orbit and relevant anatomy in each approach. Well, the orbit is the bony cavity in the skull containing the eye for each of us, and it contains the associated structures. It's a quadrangular truncated pyramid That means it's a pyramid with the apex cut off, and the base of the pyramid is actually the entrance to the orbit. Its size is vertically 35 millimeters by horizontally 40 millimeters. So it's slightly wider horizontally than vertically. The volume of the orbit is 30 cc, and 7 cc of that is occupied by the globe. So when we think of it in a volume of less than 2 tablespoons, all these critical structures, the optic nerve, the vessels, the motor and sensory nerves, the muscles, everything is crammed together in that smaller space. And another interesting bit of information we should know is that the widest dimension of the orbit is not at the entrance, but it's just 1 centimeter deep to the orbital rim. Well, how does that matter? It matters in this way. Supposing you're trying to remove an orbital tumor and you feel your opening is not big enough, you can actually drill down a little bit of the orbital rim. There's almost a centimeter of overhang, and you can drill that down and make extraction of the tumor easier. The 2 orbits are placed in a slight angle to each other. So that's how the lateral part of the eye is more exposed than the medial part. And each of these orbits is placed at a 45-degree angle to the sagittal plane. So ultimately, we'll see that we use a pen. The lateral walls of the 2 orbits are at 90 degrees to each other. The medial wall has a depth of about 45 millimeters. Keep that in mind, and we'll come to that later. In addition, the 2 medial walls are about a distance of 2.5 centimeters from each other. The distance from the back of the globe to the apex of the orbit is 18 millimeters. However, the optic nerve that we have is about 30 millimeters. That means the optic nerve has a certain degree of freedom. It is able to be sinuous and S-shaped condition instead of being straight. How that helps us is that it does not get stretched with every movement of the eye. And in fact, the eye is able to take a certain amount of proptosis without developing a neuropathy. Among the relations of the orbit, the most important are the paranasal sinuses. Superiorly, the frontal sinus, medially, the ethmoid sinus, and inferiorly, the maxillary sinus. So the floor of the frontal sinus is part of the roof of the orbit, while the floor of the maxillary sinus is the floor of the orbit, while the roof of the maxillary sinus is the floor of the orbit. And one sinus we often tend to forget is actually the sphenoid sinus, which is behind the ethmoid sinus, and it is in very close proximity to the orbital apex. So an infection in the sphenoid sinus has the potential to spill over and actually threaten the vision. Now we'll start off with the walls of the orbit, starting with the medial wall. The medial wall of the orbit from front to back is made up of the maxillary bone, the lacrimal, the ethmoidal, and the sphenoidal bones. The medial wall is the thinnest of the walls with the lamina papyracea. So this is pretty easy to break when we are trying to do an orbital decompression. But it also means that it fractures quite easily. So the medial wall, if you'll see, the maxillary bone makes up the anterior lacrimal crest, while the lacrimal bone makes up the posterior lacrimal crest, defining the anterior and posterior boundaries of the lacrimal fossa where the lacrimal sac is lodged. So when we go transcaruncular and enter the medial orbit, we are targeting to go behind that, keeping the lacrimal fossa and the lacrimal sac safe. The superior boundary of the medial wall of the orbit, right here, is the suture, the frontoethmoidal suture, the suture between the frontal bone and the ethmoid bone. it has certain important structures, the anterior ethmoidal foramen and the posterior ethmoidal foramen. And here comes in a little bit of very interesting calculations. Approximately, when we start entering the medial wall of the orbit, approximately 24 millimeters in is the anterior ethmoidal foramen. Another 12 millimeters in is the posterior ethmoid foramen, and another 6 millimeters in is the orbital apex. So why is that important? Well, when we are operating on the medial wall of the orbit, these foramina have neurovascular bundles. And so, there's a potential of heavy bleeding from these places. And say we are operating on the medial wall of the orbit here. Once we reach the posterior ethmoid foramina, we need to be very careful that we are not going too far back, because then we are going to reach the optic canal, and there's a potential of injuring the optic nerve. The other part that we look at when we are, say, decompressing the medial wall of the orbit, when we are looking at the frontoethmoidal suture here, we don't want to go above that, because what do we have here? We have the anterior cranial fossa. And so therefore, if we breach that area, we are going to end up with a CSF leak. So that is about the superior boundary of the medial wall. How about the inferior boundary? Well, the inferior boundary of the medial wall slopes imperceptibly and merges with the maxillary bone down. So here the bone is much thicker. And if you look at the CT scan here, this is the area we are talking about. This is called the inferomedial orbital strut. Sometimes if there's a major fracture, if this bone is gone, there's a tendency for the globe to go into hypoglobus because it is no longer supported. Similarly, when we are doing orbital decompression, we try to make sure that this particular area of bone here is present. We don't take it off. Once again, to prevent the globe from sinking down and going into hypoglobus. The floor of the orbit is triangular and it slopes upwards. And this slope is important to remember when we are repairing an orbital fracture. If we just place an orbital implant, a floor implant horizontally, we would end up displacing it into the maxillary sinus. So the plate has to be designed and angled to slope gently upwards. Now, this floor of the orbit is made up majorly of the maxillary bone, but the zygomatic bone and a little bit of the palatine bone contribute to it. The medial part, the posterior-medial part of the floor of the orbit is the most prone to fracture. And just remember, just above it, we have the inferior oblique, we have the inferior rectus, the fascia of the muscles, and the fat. So if these prolapse into the maxillary sinus and get entrapped, then there's a limitation of the upward movement of the eye. The inferior orbital fissure here on the lateral part of the floor divides the floor from the lateral wall. And through here come the branches, the maxillary branch of the trigeminal nerve. So what do these nerves do? These are the sensory nerves, one of which goes into the infraorbital canal, which is somewhere here. On a cadaver, or in fact, actually, while you're operating on a patient, the bone is so thin and translucent that area of the infraorbital canal is pretty well seen. And when we are operating, we try not to damage that canal, otherwise the patient ends up with hypostasia. And a patient of injury post-fracture may actually have hypostasia because the infraorbital nerve is damaged and there is a numbness over the cheek, lips, gums, and upper teeth. The lateral wall of the orbit is the thickest wall. It comprises the crater wing of sphenoid and the zygomatic bone. So it's limited, bounded superiorly by the superior orbital fissure posteriorly and inferiorly by the inferior orbital fissure. So superiorly, the frontosphenoid suture here, this comprises the boundary between the lateral wall and the roof of the orbit. And this is also an area of communication between the external carotid artery and the internal carotid artery. The internal carotid artery, a branch of which is the ophthalmic artery coming from the optic canal here, that can communicate through this suture with the middle meningeal artery, which is a branch of the external carotid artery. So once again, when we are operating in the superotemporal part of the orbit, this is something we have to be very conscious about, and otherwise the blood may start spurting. Looking at the lateral wall of the orbit, we also see a couple of foramina. There are lots of foramina around the orbit, but we have to be conscious of where each one is. So we have the zygomaticofacial and the zygomaticotemporal foramina, which convey the similar named vessels and nerves. Once again, when we are operating, we need to be conscious to stop the bleeding from these places. Also on the lateral orbit, a little posterior to the rim, is the Whitnell's tubercle. Now, let's remember that the Whitnell's ligament does not attach to the Whitnell's tubercle. So what does attach? Well, a bunch of L's. The lateral horn of the levator, the check ligament of the lateral rectus, the lateral canthal tendon, and Lockwood's ligament, which is the suspensory ligament of the globe. When we are operating on the lateral wall of the orbit, if we are actually putting an incision in the periosteum on the rim and lifting off the entire periosteum carefully, these things remain intact and unharmed. And so at the end of the surgery, when we close the periosteum neatly, the structures function just as before. Also to remember that the sphenoid bone, the greater wing of the sphenoid bone in the lateral wall, separates the orbit from the temporal fossa here, but also from the anterior cranial fossa, particularly in a deep lateral wall decompression in thyroid orbitopathy. This is the area of the bone that we drill off. And there is a possibility that one can breach this bone here and have a CSF leak. The roof of the orbit forms the floor of the anterior cranial fossa and part of the floor of the frontal sinus as well. And this is a little variable. And it is made up of the frontal bone and the lesser wing of sphenoid. Remember, the greater wing of sphenoid was part of the lateral wall. So what do we have as relations, landmarks on the roof of the orbit? We have the supraorbital notch or supraorbital foramen in some patients. It may not always be a closed foramen. And we also have the trochlear notch. The trochlear notch is where the fibrous pulley of the trochlea is present. So when we are operating on the superior orbital rim, we can be very carefully peeling off the periosteum here, along with the trochlea, keeping it intact. So if we are rough with this area, there is a possibility that the trochlea is going to develop fibrosis. And then there's going to be an acquired Brown syndrome because of inability of the superior oblique to act properly. The superior supraorbital notch and the supratrochlear notch convey the similarly named vessels and sensory nerves. On the temporal part of the roof of the orbit is the lacrimal fossa with the lacrimal gland. So once again, when we are entering, we should not mistake the orbital lobe of the lacrimal gland to be fat or excise it. We need to differentiate it carefully. Once we've dealt with the walls of the orbit, let's come to the most complex part of the orbit, which is the orbital apex, the tip of the pyramid. Okay, so this is an area of communication between the orbit and the cranium, and it's absolutely crowded with neurovascular structures. In fact, it's like any lesion there, without producing a major symptom, major proptosis, can actually cause major diminution of function, both motor, sensory, as well as visual function. And the optic canal here is made up partly by the lesser wing of sphenoid and partly by the strut joining the lesser wing to the clinoid process. However, in 42% of the patients, this area is actually taken up by the posterior ethmoid cells, also called the Ono de air cells. So sometimes in very aggressive sinus surgery, there is a potential for the optic nerve to get damaged here. When we look at the complex of the optic canal and the superior orbital fissure, the fibrous circular band, the annulus of Zinn, sort of straddles the two structures. So what do we have here on the outer part? We have the structures LFT, of course, as you know, the lacrimal, frontal, and trochlear nerves, and the superior ophthalmic vein. Within the annulus of Zinn, we have the ophthalmic artery and the optic nerve. And coming in from the superior orbital fissure are the superior and inferior divisions of oculomotor nerves, nasociliary nerve, and abducens nerve. These are, so that's a combination of motor and sensory nerves. And the four recti, as well as the levator, originate from the annulus of Zinn. So let us look at what these nerves and vessels are doing. We have here the apex and the superior orbital fissure. We have the lacrimal nerve supplying the lacrimal gland, and all of them supply the skin around it. The the frontal nerve, which divides into the supraorbital and the supratrochlear branch. The nasociliary nerve, which gives branches to the anterior and posterior ethmoidal foramina, and then ends up as the infratrochlear nerve. The maxillary division of the trigeminal nerve. Now that divides into the infraorbital nerve, as we talked about, as well as the zygomaticotemporal and the zygomaticofacial nerves. How is this important for us as surgeons? Well, all of these nerves are amenable to nerve blocks when we are doing periocular surgery using a very small amount of local anesthetic. If we know the exact location of these nerves, we can block them to create good anesthesia. Now, we remember that the ophthalmic artery came in along with the optic nerve. Now, that also starts branching, and most of these branches accompany the similarly named sensory nerves. When we think of the extraocular muscles, as we said, the four recti start from the annulus of Zinn. The superior rectus and the levator palpebrae superioris start together, and almost at the equator of the globe, they separate out, the levator going to the eyelid and superior rectus attaching to the globe. The superior oblique starts from the lesser wing of the sphenoid and makes a turn through the pulley at the trochlea. Now, the superior oblique is supplied by the trochlear nerve, and the other muscles, the superior rectus and the levator, are supplied by the superior division of the oculomotor nerve, which enter the muscle through the junction of the posterior 1/3 and anterior 2/3 on the inner surface. Similarly, the inferior division of the oculomotor nerve supplies the inferior rectus, inferior oblique, and medial rectus, once again from the inner surface. So inner surface, posterior 1/3 and anterior 2/3. So that is kind of an idea of where you should not be, messing around during orbital surgery. The branch to inferior oblique traces the lateral edge of the inferior rectus muscle, and that also has the ciliary ganglion attached to it, which would give rise to the short ciliary nerves. Now, these muscles do not exist in a vacuum. There is the orbital fat all around, but also very importantly, there are the fibrous septae connecting the different muscles as well as dividing the orbital fat into pockets. And these septae play a major role in defining the surgical spaces of the orbit. The recti together, if you see, together will form a kind of shape of a cone. Okay, a circle at the anterior, and because they all start from the apex, they narrow down to a point like a cone. So then we have the intraconal surgical space. The space outside the recti is the extraconal surgical space. The subperiosteal surgical space is probably the tightest and best defined because it's the periosteum of each bone. So in each bone, the subperiosteal collection, say a subperiosteal hematoma or a subperiosteal abscess, is limited by the sutures of that particular bone. So now we talk about the incisions of the orbit. Even though a lot of incisions are mentioned, practically everything in the orbit can be reached through these three incisions: the upper lid crease extended incision, transcarancular, and swinging eyelid inferior transconjunctival incision. Why swinging eyelid? Well, by doing a canthotomy and cantholysis here at the lateral canthus, the entire lower lid will swing out like a door, so giving us good access inferiorly. Upper lid crease incision would be useful to tackle a superior orbital tumor or a subperiosteal hematoma. So when we are going through this, we might encounter the levator, the superior oblique, superior rectus, superior division of the oculomotor nerves, and supratrochlear and supraorbital nerves. The supratrochlear and supraorbital nerves, if breached, will cause loss of sensation, and later, as they recover, they'll cause paresthesia. But levator can cause ptosis, and superior oblique and superior rectus, the vertical muscles, not only can they cause vertical diplopia, they can also cause torsional diplopia, which is very, very difficult for the patient. So these are the things we have to be very aware of. When we extend the upper lid crease incision, we can actually access the lacrimal gland tumor, intraconal tumors, as well as the deep lateral wall compression. Remember, we talked about the lateral wall is set further back because of the tilted position of the orbit, which means when we go just a little bit along the lateral wall, we can get into the intraconal space quite easily. So what do we encounter here? We can encounter the lateral rectus. During decompression, we might end up with a CSF leak because as we looked, just behind the lateral wall is the anterior cranial fossa and the ciliary ganglion. If the ciliary ganglion has been damaged during a trauma, say in an orbital fracture patient, or if we ourselves damage it, we are going to end up with a dilated pupil. No afferent defect though, remember. So during surgery, it might be pretty alarming to the surgeon as to what's happening, the pupil is dilating. It's not always the optic nerve that is damaged. If we've damaged the ciliary ganglion, even then the pupil is going to dilate. A transcaruncular incision is the ideal one to get to the medial orbital tumor, medial wall decompression, or medial wall fracture repair. So this is something where a medial rectus can be damaged. And in fact, the medial rectus is so closely adherent to the medial wall of the orbit, a little aggressive sinus surgery can manage to damage the medial rectus. And let us remember the relationships we learned while looking at the medial wall. About 40 to 45 millimeters in is the optic canal with the optic nerve. So we have to be very aware when operating on the medial wall. Inferior conjunctival and swinging eyelid approach can also get us to an intraconal space. Look at this tumor, which is so large here. But if you open the inferior wall here, you can actually go approach this tumor pretty straightforwardly. And there's no vital structure here. Between the lateral rectus will be somewhere here, the inferior rectus is somewhere here. This inferotemporal quadrant is probably one of the safest quadrants to operate in the orbit. A little medially, though, you have the inferior rectus and the inferior oblique and the ciliary ganglion, as we've been talking about. So to summarize, we talked about the overview and dimensions, the walls of the orbit, the relationship of muscles, nerves, and blood vessels, and the various approaches to the orbit along with the relevant anatomy. Thank you.
Dr. Roshmi, that was an absolute treat. Your lecture has covered salient features and very important aspects. Thank you very much for your very exhaustive and excellent journey across the orbit in a very practical sense as well.
Thank you.
I would love the audience to ask some questions on the chat box, and we have a few minutes time where we can take up your questions. And I'm sure Dr. Roshmi will be very happy to answer them. GHA, is there a way the audience can unmute, or they have to type the questions in the chat box?
Yes, doctor. They can unmute, doctor. 1 minute, doctor.
Okay, if there is anyone who wants to ask a question, please indicate, please raise your hand and we will be able to unmute you and take up your question. Meanwhile, this session today has been like a start off for the upcoming session that we have in Bangalore, which is a cadaver hands-on workshop, where Dr. Roshmi is going to handhold you into dissection of the orbit. She has a very beautiful plan laid out based on your interest and based on the area that you want to understand. Dr. Roshmi, would you like to give a little bit of what is the plan of teaching that you have for our students on the workshop? And along with Dr. Roshmi, there are going to be other co-faculty as well. So we want to keep it as a very well guided session where you have faculty next to you when you are doing the procedure on the cadaver. Dr. Roshmi, is there any little bit information that you can give?
Yes, Jayashree, thank you. So our whole aim in this particular workshop is to make it as personalized as possible. Okay, so we have the topics of orbitotomy and orbital decompression for thyroid eye disease, as well as frontalis flap advancement and a median forehead flap. So the people can choose whichever one they really want to learn. And there will be one-on-one hand-holding on practicing this. So if you would have understood from the lecture, there are a lot of pitfalls while operating in the orbit. And obviously, on a patient, you can't really experiment that, okay, what happens if I go a little more right? What happens if I go a little more left? Okay, you are kind of given the parameters and you are almost blind because you're not going to fiddle around and look at the other structures. But this is where it comes in, that you are guided through the steps of the surgery, but you are also able to kind of peel back the layers and structures around where you're operating and actually see, the elements instead of being only theoretical about it. So that gives a very good grounding of, very good 3D memory to carry.
Absolutely. I'm sure I for one, I'm looking forward to this as an intraocular person. Most of the times in our post-graduation, we are covered the intraocular, the cataract is the majority of what we study. So then mostly it is very alien for us, the extraocular part and the orbit. And it's really going to be something wonderful that I'm sure people would want to make use of.
And I'd actually like to talk about the course faculty. Dr. Anjali and Dr. Ajay are a couple of the most patient people I have come across. I've seen them assist people. They are so patient.
I'm sure this is going to be a wonderful team. There is a question from one of the participants who's asking if maxillofacial surgeons can be part of this offline cadaver hands-on. To tell you, like, I'm not saying a direct no. This particular workshop on the May 27th is designed keeping ophthalmologists in mind. The entire content is curated and the whole program is designed keeping ophthalmologists in mind. However, we might shortly come up with something which is like more useful to you and what is your area that you would want to, that you usually deal with in your practice. So then you just keep looking forward to, us and hear more. Shortly, maybe we'll come up with a course just, for you. However, this we are like trying to keep the group exclusive to ophthalmologists so that the discussions are also, we all learn from each other and all the discussions will be relevant to the practice for ophthalmologists. Is there anything else? There's something else I see on the chat box. So, yeah. Sure, Dr. Nishit.
Okay, thank you, people. This has been a lovely evening, and thank you for giving up some of your Saturday to share my passion. I feel, when I talk about the orbit, I feel so enthusiastic. I feel that it's so much fun, and I'm so glad to see so many of you feel the same way.
Yeah, so glad to have you here, Dr. Roshmi, and I'm so happy to be moderating this session. And there's something extra I want to just suggest that you all could, avail this early bird price. The session is actually the offline event. Workshop is priced at 50,000 plus GST, but now we are keeping it absolute cost price because we are going to have only 16. The intake is going to be only 16 candidates, 1-6. We don't want to crowd the session. And like Dr. Roshmi said, we want to keep it very intensive so that you go back home with a feeling of that you've really learned and feeling confident about spending that one day with us. So that is why the price is so. And if you can just avail this early bird discount now, then I think our seats will be full already. Okay, so I encourage you to reach out to us and avail this early bird price, which is probably, I think, on till another few days. So since you've already experienced the teaching style from Dr. Roshmi, I'm sure you're looking forward to actually meeting her in person and being part of her workshop. So I welcome you all to register and see you all in Bangalore. Thank you so much for this lovely opportunity to moderate this session. Thank you, GHA. Bye, everyone.
Bye.
Thank you, doctor.